So welcome again to our webinar for today. This is part of our Be Well Talk series. And so today's talk is on exercise and bone metastases. So I'm very pleased to introduce our speaker for today. So today we've got Dr. Kristen Campo with us today. So Kristen is a licensed physical therapist and a professor in the Department of Physical Therapy at the University of British Columbia in Vancouver. She is also an affiliated scientist in the Cancer Control Program at the BC Cancer Research Institute. Her research focuses on the role of exercise in cancer rehabilitation and survivorship. She has published over 150 peer-reviewed papers, and she was the co-lead of the 2019 Exercise Guidelines for Cancer Survivors from the American College of Sports Medicine. So Kristen, thank you so much for being here with us today, and I will hand it over to you.
Thank you so much for the invitation to speak to this group and for the kind introduction. I will be looking, I have too many screens, so I'm going to be looking over here as I present, but I also wanted to just highlight that one of the other people who's sort of very involved in this research, who's sort of integrated into everything you're going to hear today, is Dr. Sarah Neal-Stramko. She's the co-principal investigator on our bone metastases and exercise work. She wasn't able to come today for a tag team, but I do want to highlight that she's an assistant professor in the Department of Health Research Methods, Evidence, and Impact at McMaster University, and the Knowledge Translation Advisor to the National Collaborating Center for Methods and Tools. Her academic training and research is really informed by kinesiology, population and public health, knowledge translation, and implementation science. That is why you'll see she's a vital team member to this. And the goal of her work really is to increase uptake of evidence-based interventions into the community or by practitioners. So just as a brief introduction before we get and we have someone raising their hand, so I'm going to let you, our host, deal with that. So in terms of the role of exercise as part of cancer care, before we get into bone metastases, just kind of giving a framework of sort of where exercise has sat in the cancer care continuum. And really, we are a bit late to the party compared to things like cardiovascular disease and diabetes, where getting people moving and the role of potentially structured exercise as part of the supportive care provided has been more commonly integrated into care. For cancer, really, we're sort of maybe 50 years behind. The first studies were really around safety in the 1980s. Could people who were receiving chemotherapy even start to think about adding activity into their day around times of treatment? 1990s really focusing on the potential benefits of exercise as part of supportive care to manage quality of life, feelings of well-being. The 2000s is where we focused a bit more on exercise prescription. So trying to understand exercise dosing, what type of approaches could be used to prescribe exercise for this group most effectively. The 2010s really focusing on the first exercise guidelines that were published in 2010, and then specific side effects. So if we're interested in addressing cancer-related fatigue, what does an exercise prescription for that look like, as opposed to peripheral neuropathy or managing physical function? The 2020s, here we are, a lot of focus on the second exercise guidelines, which I cheated a little bit. I popped it into 2020s, really focusing on optimal prescriptions and then clinical endpoints. So while exercise does improve quality of life, physical function, are there other things that are related to the cancer outcomes that are really important to the cancer care group? So ability to receive all the treatments that you're being prescribed. So chemotherapy tolerance, for example, improvements in survival, hospitalizations, those sorts of things. And into the future, I think where we are now is that there's still research being done on understanding how to dose exercise and how to prescribe exercise and what it can benefit. But I think there's a solid amount of evidence, and you'll see that in the next slide, to show that we need to start implementing this into standard of care to improve the supportive care options for people. So these are the current physical activity guidelines for people living with and beyond cancer, published in 2019. Overall is to get started, avoid inactivity, moving more and sitting less, or I would say moving more just benefits nearly everyone. And for overall health, the guidelines are still the same as the current physical activity guidelines for Canadians. the standard moderate to vigorous intensity activity with resistance training. What the 2019 guidelines really added to what we had is these kind of symptom-specific guidelines. So what we saw with the 2019 guidelines is that we can now give prescriptions for managing cancer and cancer treatment-related side effects. So how this infographic works is that cancer-related fatigue is in green. And what we saw when we looked at all the evidence available in meta-analyses, systematic reviews, was that a prescription of about 3 times per week of aerobic exercise, moderate intensity, at least 30 to 60 minutes per week, really helped to manage fatigue, for example, as well as health-related quality of life, physical function, anxiety, depression, and potentially sleep as well. What we also showed is that resistance training on its own, 2 days a week, 2 sets, 8 to 15 reps of pretty standard large body, large muscle exercises, also was potentially beneficial on its own for fatigue, health-related quality of life, physical function. There is some, the lymphedema recommendation is mostly around safety, and bone health has a slightly different description, which we can talk about if anyone has questions. Or you can do the combination of the two. If you do that, you get to a little bit of aerobic activity as long as you're adding resistance training in. So now it's only maybe 2 days a week at 20 minutes to still see some of these same benefits. And I think the goal for this for an exercise audience, for if you're working in this field and you're looking at prescribing exercise, is kind of now a little bit more nuance and a lower exercise target to start seeing some of the benefits of activity. So at least 30 minutes, 3 times a week, 2 days a week of strength training. We did consistently see that supervised exercise had a greater effect than sort of more home-based, traditional home-based exercise where people are just given things to do on their own. So I think that's the big kind of where we are with the prescription piece. So why are we focusing on bone metastases? The main focus of today's conversation is that we recognize that people with advanced cancer who had gone under serial cycles of cancer treatments potentially end up with quite a high symptom burden, and that exercise could and physical activity could be really beneficial for this group, but they were consistently left out of the research that we were able to use to inform the guidelines I just showed you. So there was a real gap for advanced cancer, specifically with bone metastases. On the flip side of that, maintenance of functional independence, managing symptoms was reported by people with advanced cancer to be a top priority. So there's kind of a disconnect between what's available, what evidence we had, what the priority of individuals was, and in the middle is the healthcare provider and exercise professional, especially in the bone metastases context, concerned about skeletal complications with providing exercise recommendations, and really uncertainty around the right risk management approach. As a result, typically people with bone metastases then we're kind of left with not a lot of guidance, with some interest in being active because they knew it might help with their physical function, but their care team felt very unsure about what to report. So this is where we brought together the International Bone Metastases and Exercise Working Group. We met together in 2019 in person, and it was an international multidisciplinary group that came together to review the evidence and try to come up with an initial framework for exercise professionals and members of the healthcare team to improve and integrate exercise programming for people with bone metastases. What we basically did is we had a preliminary meeting in 2018 to set us up for the 2019 meeting. We undertook a series of activities to try and understand what was available in the literature and what we could add to the literature in order to kind of get to a place where we could do recommendations. We did a physician and nurse practitioner survey in British Columbia, a modified Delphi consensus process with exercise professionals, healthcare providers around the world. And we also did a systematic review trying to look at what was available around exercise for people living with bone metastases. We brought all that information to our in-person meeting that you just saw a picture of, and we developed some recommendations. We then sent those recommendations out for stakeholder engagement. We asked people, what are we missing? Does this terminology work for you? Really getting some strong feedback on that. And then we finalized the recommendations, and they were published in JCO Oncology Practice in 2022. Just a snippet of kind of what we found with our nurse practitioner and physician survey. Most felt that exercise was important and could be safe for this group of people living with bone metastases. They perceived that the patients looked to them for advice and recommendations. But on the flip side, 86% felt they required more information to even make a recommendation. They didn't know who to send people to in the community. They didn't know what to tell people. So patients want the information from them. They aren't sure what to say. For our systematic review, we looked at really, was exercise safe in this group? Was it feasible? And was it beneficial? So some questions are, with advanced cancer, knowing the symptom burden and the potential treatment accumulations, would people be able to even participate in exercise? And the answer is yes. 70 to 80% attendance, adherence, and retention. So no different than people in an early stage cancer context, for example. For safety, there were 4 serious adverse events. So that meant hospitalization, medical attention required. All of these happen to be soccer related, pardon me, in study in Denmark, and none actually were related to the site of bone metastases. A lot of the Achilles tendon ruptures and ankle breaks. So enthusiastic soccer. And then in terms of beneficial, would this group see the potential benefit that we've seen with individuals doing exercise in the early stage cancer setting? And there was preliminary efficacy that favored exercise to improve physical function, muscle strength, quality of life, and fatigue. There weren't quite enough number of studies and large enough population of people who had been in the studies to be definitive, but it definitely showed a trend that the same benefits should be seen. The modified Delphi process here, just to highlight to you, we asked questions about risk stratification, pre-exercise screening, exercise testing, prescription and monitoring, like getting into the nitty-gritty with our experts. Majority of people who responded were PTs or clinical exercise physiologists, majority from Canada, but we had a good representation from around the world. So at the end of the day, the overarching recommendation that this work provided was that regular exercise has the potential to maintain or improve physical function and health-related quality of life in people with bone metastases, and the perceived risk of skeletal complication should be weighed against the potential health benefits. This is ultimately the message we really wanted to get across, knowing that this had been a bit of a gap in the literature. There are 5 recommendations. I'm just going to quickly highlight, I think, 4 of them today. First recommendation, before exercise testing or training, perform a risk assessment to inform the likelihood of a skeletal complication from exercise. So this is this risk stratification process. Well, we all wanted an easy recipe for those that work in this field, especially with those individuals who have advanced cancer or have bone metastases. The presentations are so varied and heterogeneous that a red light, green light, yellow light was just not possible. What we said then is this constellation of factors that need to be considered and discussed with everybody involved, the healthcare provider, the exercise professional, the person, and their own goals to kind of see where you land on that risk-benefit criteria. It really was looking at lesion-related factors, cancer and cancer treatment-related factors, and person-related factors. And you can see examples of those there. So for lesion-related types of lesions, where they're located, the size. Cancer treatment, what's the cancer diagnosis? Kind of what's the progression and prognosis for this disease? Management of the bone lesions. Have they had either surgical or radiation or other interventions done, or are they planned? And then looking at things like pain, severity, location, use of medications, any neurological symptoms like sudden or new progression of loss of bowel and bladder function, other impairments, falls, things like that. And then for the person-related factors, like their overall medical profile, any limitations with ADLs or mobility, cognitive impairment was a big one because a lot of the recommendation is around moving with good posture and good alignment. And so if you didn't feel that an individual could reliably follow the precautions and the instructions you're giving, that may also change kind of where you land on this risk-benefit profile. And prior exercise history. Anyone here on the call that's taught people how to hinge or squat, you know that some people have done a lot of this in the past, and so it's just kind of reinforcing and getting things tinkered. Other people, this is all new, and so that may also impact kind of how you approach the prescription piece when people are just learning about good postural awareness. Recommendation 2, consultation with the medical team is strongly encouraged before an exercise professional provides structured exercise for a person with bone metastases to obtain key medical information and establish bi-directional communication for initial assessment and exercise training throughout care. This was time and time again, the challenge that people reported to us is that the healthcare team holds all the information about the cancer diagnosis, the lesions, the bone scans, all the things. Typically, at least in Canada and in most places around the world, the exercise professionals work outside the primary cancer care setting. They can't see the electronic medical records. Or for those that do work in there and can, looking at bone scans is not really our scope of practice. So getting some guidance from the healthcare team of sort of what their impression of that is important. So we'll talk about what we tried to do to fix that. Here we have a recommendation number 3. We asked people kind of what the bar is for who you think is the right professional to work with this kind of more complex patient population. And so across the board, it was agreed that exercise professionals best suited to prescribe exercise to people with bone metastases are physical or physiotherapists in Canada and clinical exercise physiologists or the equivalent in your jurisdiction who have additional cancer training and appropriate experience working with people with a cancer diagnosis. The minimum that was sort of endorsed was a university level education, just knowing that that's kind of a more robust, potentially focus on the chronic disease population and also fits with the scope of practice of the individuals once they've kind of gone on to work in the community. This is not a blanket statement, but it was sort of the starting point that we thought was the most effective approach to start with from a safety standpoint. Recommendation 5, we skipped 4. It's, a lot of information. You can go and check it out in the paper. Here, really, that the exercise prescription should follow the standard exercise recommendations as outlined by the International Exercise Guidelines for Cancer Survivors, which you've seen previously, with greater emphasis on postural alignment, control movement, and proper techniques, as well as consideration given to the location and presentation of bone lesions. Formal monitoring of exercise response and adjustment of exercise prescription should be ongoing. So this is the kind of thing, just to highlight this as continuous monitoring comment, is that for this group, before and after each session, or for a complex individual, maybe before and after each exercise, or you're adding a new exercise, you ask about pain or changes in pain and pain medication use. Ask about or check into neurological symptoms and any new or changes in limitations of movement or ADLs. Knowing that you just want to monitor how the response is going and be able to be adaptive with your prescription if someone is reporting more pain as a result of working with you or adding a new exercise. Like you just add a squat, for example, and they're like, no, that's starting to feel a little bit uncomfortable. You're like, great, we'll do something completely different. These recommendations have been endorsed by a variety of exercise or oncology organizations professionally around the world. So that has also been a nice endorsement as well. But, and this is where Sarah Neal-Stramko, who I mentioned, plays a critical role, we know that recommendations are not enough to change practice. And so we wanted to go a further step to try and ensure that people can use this information. So we undertook experience-based co-design. We collaborated with knowledge users to develop knowledge mobilization products, which is a fancy way to say things like patient handouts. And we also wanted to do a dissemination plan to promote the adoption of these exercise recommendations. Who do we need to reach out to? And by the way, talking to people at Wellspring is part of our dissemination plan. So thank you for being part of this. Also, I want to highlight, we're fortunate to have a partnership officially with the Cancer Information Team at the Canadian Cancer Society. These are the people that generate their website and all the materials that go onto their website, which are excellent. And so they provided really valuable insight into plain language, content design, and the format of the knowledge mobilization products. And we are extremely grateful for their expertise in this area. So this is just a bit about kind of what we did. We brought together, and sorry for the a bit of a jumble here. I put the slides onto the Wellspring template and things, mostly worked out okay. Here we had oncology healthcare professionals, so oncologists, nurses, other allied health professionals beyond physiotherapists, people with lived experience and their family members, and also clinical exercise physiologists. So these were certified exercise physiologists, or clinical exercise physiologists, and physiotherapists. What we did is each of these groups met on their own to say, kind of what are the knowledge products you think you need as a priority to do this kind of translation of research to practice. Then the second meeting, everybody came together with their lists and we sort of said, okay, how do we all agree on kind of maybe the 4 or 5 things we're going to tackle? Meeting 3, we started drafting out the language and what these things were going to say. And meeting 4 was kind of like the finalization of like how it looked, all the terminology. We then solicited feedback. So we sent these draft knowledge products for review to people internationally. And so you can see here we had about 70 people reply across all the different kind of disciplines that knowledge user groups we were hoping to get. And this is just an example of kind of what happened at that stage. We sent them out and said, like, don't get stuck on the formatting, but like, tell us about the language. And we got really helpful feedback around kind of like how this would, how people would interpret this when they saw the actual tools. So extremely helpful. So this is the final result. Ta-da, the Bone Metastases Exercise Hub. So you'll see there are 5 sort of main knowledge products that were developed. The first is an educational webinar. That is myself and Michelle Nadler, a medical oncologist in Ontario, in the English version. And because the Canadian Cancer Society is serving Canada, everything is also translated into French. So we have a colleague, Sebastien Dufresne from Quebec, who he's a physiotherapist and did the physiotherapy spot for the webinar. And Michelle Nadler is bilingual. So she did the medical oncology bit on both ends. We have a patient handout available in English and French. The communication tool, I'm going to focus a little bit about this on the next slide. Patient video, so how to use the communication tool. And finally, an exercise directory. So this connects people to clinical exercise physiology, basically CSEP's directory. And then every professional organization in each province for physiotherapy has a link here as well. You can find the Bone Metastases Exercise Hub using this QR code or through this sort of short URL. The interesting thing too is that when we first presented this, we then had tons of interest internationally. So now it's been translated into Swedish, Spanish, Japanese, German, Dutch, and we've even adapted it for other countries that are English speaking primarily, using slightly different terminology and tailoring the exercise professional directory more for the different country audiences. The need for the communication tool, I think, was the one thing that was sort of the most challenging or new that we really wanted to tackle with this. And so what we recognized is that we need communication between the person living with bone metastases, the healthcare provider that sort of holds that information about the lesions and the plan for the lesions and the plan for the cancer treatment, and the exercise professional. All people hold a piece of this puzzle, and we really need a team-based approach for this pre-exercise history and kind of the planning. Like, what's the plan? What's our goal? If someone really wants to ski, how are we going to make that possible? Other people that are very concerned about moving at all. They are very concerned about a skeletal complication, rightly so. No one wants to have that happen. What's the right approach to take with that group? So this is really the piece of the health information tool and the goal. So the solution is the health tool. It is patient-led. So this was designed this way to potentially avoid the challenges around information sharing and privacy and confidentiality. The patient themselves owns the form. They take the form to the medical oncologist and say, can you help me fill in this form? For the form, and asking the oncology team or the GP to fill it in, highlighting that we just want the key information that as an exercise professional in the community, I cannot easily get. This form will complement the health history and exercise screening questions asked by a qualified exercise professional. We will do our same history. We will do our same assessments. Like, we will get the other information, but what we need from you is things are like, if you look at the form, where's the location of the bone metastases? Have there been previous pathological fractures? Are there areas of clinical concern? Are there other general things that you'd want to tell me about this patient? Plan treatment. Are they using medications like opioids? And do they have any current corticosteroid medication, which can also potentially impact overall bone health? So this is kind of what we were asking the provider to provide to us. And for anyone that's an exercise professional on the call, we're going to find previous medical history and usual activities, all that stuff. We're going to do that. And we just wanted to highlight for the team that this isn't all you're going to provide. Don't worry, we're still doing our due diligence as exercise professionals on the back end when we receive the form. Also, a key piece here is that if there's a change in symptoms, there's a clear message at the bottom that says, talk to your healthcare professional or exercise professional, and you may need to update the form. Knowing that this presentation can change and that this form is not a be-all, end-all forever. It's like, here's what the snapshot is now, it may change. There is a patient video, it's about 5 minutes long, about how to use the forms to kind of walk a patient through, get the form to the healthcare team, get it to the exercise professional, why and how. And we thank the team at Princess Margaret who have expertise in doing these videos for making this. This is our dissemination plan, just a snapshot highlight. We've done a lot on social media. You can see there the variety of different options. We did a targeted email outreach. I'm sure Wellspring was on that list. And we had responses from individuals who then, and organizations who then found ways to amplify the hub in their own organization through newsletters or other things. We've had the opportunity to do a lot of conference presentations around the world, internationally at exercise and oncology focused meetings. The Knowledge Hub has had, in the first 5 months, which was the end of October, close to 6,000 unique users and over 8,000 views. And we're tracking other media stories, user stories, public presentations, etc. So in summary, I think we all recognize that public recommendations are not enough to change practice. There's a high interest in engagement from knowledge users throughout the experience-based co-design process, which suggested to us there is a high need for these knowledge mobilization products. This was a project when we asked people if they'd be interested in participating, people said yes, like faster than we could even imagine. And so I think it really said to us that the gap we identified with the original recommendations, that this whole communication piece and like having information in one place was a real gap. The partnership with the Canadian Cancer Information Team at CCS provided invaluable insight into this plain language and getting this content and making it look very professional and using best practices for communicating information to patients and the public. Targeted dissemination efforts have been successful to bring knowledge users and views to the BME Hub and international reach with the translations. Stay tuned. We are working right now mostly on a professional development course. So it'll be offered free from the UBC kind of learning platform hub. We're hoping to have it available early in 2025. And it will be kind of modular content online kind of course that you can do it yourself paced, as well as case studies. And we are working on the logistics of having people potentially attend like a Zoom like this to work through the case studies once they've done the rest of the content, maybe once or twice a year. So with that, I really like to thank everyone. I think, don't have a thank you slides on this one, but thank everyone who participated in any aspect of this. If you responded to the Delphi and you're on this call, thank you so much, or the knowledge user feedback. This was a really huge lift by a lot of people. And I really am remiss in having the final thank you slide, which we have had in other versions of this. But it was a huge team effort. So I hope that you have potentially found this useful and can check out the Bone Metastases Hub, and it will be evolving as we do some more of the work that we've got underway right now. So thank you very much, and I'll be happy to take any questions.